This is, to me, a very important lecture about the use of temperature management after cardiac arrest. I would say state of the art, what we know in 2023. I've been giving lecture for two companies, BD and Zoll, which produce TTM devices, which is very important for everyone to know when you're going to see and discuss my slides. Cardiac arrest is a situation where, the survival of the patient depends on this chain. The chain is a sequence of intervention going from early recognition of arrest to early call for the emergency medical system, if possible, early resuscitation from the bystander, CPR, and early defibrillation. And then, of course, transport to the patients, potentially in cardiac arrest centers, which have dedicated and experienced people to treat these patients. Of course, very relevant what we're going to talk today, ICU and hospital care, and for those who survive, going through rehabilitation or reinsertion to the social activity. When we talk about cardiac arrest, in particular for the ICU, most of the complications that will occur to these patients are related to the ischemia reperfusion injury. This is a very relevant paper published by Vladimir Negovsky in 1972, so 50 years ago, where he described the occurrence of reperfusion injury in these patients, which correspond to the moment where problems begin for physician to be faced and treated when patients arrive at the hospital. And this concept, which is now encompasses the definition of post-cardiac arrest syndrome, is basically composed by the precipitating cause of the arrest, the myocardial dysfunction, brain dysfunction, which is, of course, the most relevant, and the global ischemia perfusion injury, which can potentially affect each organ, the liver, the kidney, the gut. And in 2021, which is the last update of the guidelines on the post-resuscitation care, all the different points has been largely discussed, and the knowledge in what we should do after cardiac arrest has so much evolved that we went from 4 pages of post-resuscitation care in 2005 guidelines to more than 30 pages now in 2021. And of course, we will focus, because of TTM, in particularly on brain dysfunction, which accounts for 2/3 of death in the ICU for cardiac arrest survival. The approach, why we are concerned about temperature, because of course there is a primary injury, which is the anoxic injury. We can do nothing for this, but there are secondary injuries occurring at the moment of reperfusion. And the secondary injuries are enhanced, exacerbated by systemic insult. They could be metabolic disturbances, respiratory disturbances, hemodynamic disturbances, but also temperature. We have summarized the number of systemic variables which can affect secondary brain function with the acronym of GHOST-CAP, glucose, hemoglobin, oxygen. So you see here in this acronym, and temperature is a very relevant part in these patients. We have now randomized clinical trials looking at oxygen, blood pressure, CO2 management after cardiac arrest, but the most controversial randomized clinical trials in this setting concern the use of temperature. Now, the history of temperature management after cardiac arrest is a long story. Try to make it very short. It started with Peter Safari in the 60s, and then moved through a bunch of experimental evidence suggesting that hypothermia, in particular before the injury, was effective to protect the brain. Then 2001, 2002 publications in the New England Journal of Medicine with 2 small studies that led changes in guidelines 2003 and implementation of the use of hypothermia in treating basically all cardiac arrest patients. Then first observational studies saying that might not work in all patients population. 2013, the TTM1 study comparing 2 different levels of hypothermia. And then in the last years, 2 main publications, one is the hyperion study here, comparing TTM at 33 degrees with normothermia in non-linear shockable rhythms, and then the very large TTM2 published in New England Journal of Medicine, basically reproducing again the initial results in 2001, 2002, showing no benefit from this intervention in cardiac arrest patients. And because of the TTM study, we have now new recommendation on temperature management, which everyone have to know. These are the European recommendation, are not exactly what has been reported by the American Heart Association guidelines, but European recommendation said that, of course, temperature is important. We need to measure it. We need to actively prevent fever, which in the TTM2 study was identified by the body temperature exceeding 37.7. And then we shoot this for 72 hours. Of course, there is the box trial recently published comparing 72 to 24 hours, but don't have the time to go into details because the studies show that the two strategies, shorter and longer temperature control, was similar in terms of neurological recovery, but this study is very highly selected patients with cardiac arrest of cardiac origin, very high proportion of patients with good outcome, maybe not entirely generalizable to the whole population of cardiac arrest patients. And then when you you apply this normothermia approach, as soon as antipyretic do not work, you should apply a cooling device. These basically come from a TTM2 study. I was part of this study, great randomized clinical trials, 2,000 patients randomized to two different strategies. Basically, the TTM2 study, if we want to really summarize it, started from the initial ACA trial published in New England Journal of Medicine, showing that hypothermia here has a better outcome than normothermia here. In this study, normothermia was very close to fever, very close to 30 degrees. So what in this study they plan to do, what has been done, is that there was an intervention, early cooling, 24 hours hypothermia, quite short rewarming, and then fever control for 72 hours, compared to strategies in which temperature is kept below 37.8. And very importantly, in the normothermia group, only 0.5% of the patients require a device to actively and effectively keep temperature below this level, which means that in 0.5% of the patients, you will not require a device that will remain spontaneously normothermic over the study period. In one slide, the summary of the study, but I really recommend you to read this paper, showing that basically the proportion of patients who do not survive and those who have a poor neurological outcome was similar, very similar among groups. So the conclusion of the study is that in these large randomized clinical trials, including 2,000 patients with a very high quality of methodology, hypothermia did not lead to a lower 6 months incidence of death and poor neurological outcome than normothermia. And then there are at least three major, I would say, meta-analyses. One published by the ILCOR, resuscitation. The second is a network meta-analysis comparing different temperature targets among them, so 33 to 36, 33 to 37, 33 to no fever control, showing no benefit from hypothermia comparing to the different control groups. And then a Bayesian meta-analysis using, of course, a non-frequentistic approach, a more modern one, with a pre-test probability to assess which is the probability that hypothermia might work, showing that the chances that hypothermia might work are extremely low. So if you consider all this literature, I would say hypothermia is over after cardiac arrest. But of course, there are some points that require to be discussed to entirely understand the existing literature in this setting. First, hypothermia has a biological plausibility because in vitro studies, cell cultures, and in most of experimental studies, there is an effect of hypothermia as neuroprotective strategies. Of course, in some studies, it's only a reduction of histological damage, a reduction of biomarkers. We don't have a long-term neurological recovery in most of the studies. And some of those studies also show no effect of hypothermia. So it's not 100% literature going in that direction, but most of the literature still played for effectiveness of hypothermia in this setting. The second point is that when you look at existing literature, we are not, when we put all these studies together in a meta-analysis, we cannot say that these studies really evaluated the same population of patients. So putting them together, of course, is the way that we assess randomized clinical trials, but it might look a little bit artificial. When you consider the first two trials that show that hypothermia was effective to improve neurological outcome in these cardiac arrest patients, this is the ACA trial and Bernard trial in 2001, basically these studies were focusing on a very selected patient populations: shock arboretum, out of hospital cardiac arrest, witness arrest, without shock. So basically, that's probably 10% of all cardiac arrest patients that are admitted today in the ICU. So in this specific patient population, as far as we know today, there might be an effect of hypothermia. But these trials have severe methodological bias. Look at the HACA trial. There was no power calculation. It was stopped because of lack of funding, and randomization was with envelope. The Bernard trial was randomizing pre-hospital, so hypothermia was applied before hospital admission. There was a power calculation which is extremely, enthusiastic about the effect of hypothermia, and randomization was made upon the day of the month. So if you consider this methodological bias, we could say that these two papers would never been published in New England Journal of Medicine today, but still are relevant for existing literature. When you move to TTM2, of course, TTM2 was very large, great methodology, but still in a population that might not reflect in all the countries all over the world the kind of patients you see in your emergency department, your ICU. This was a study with 90% by standard cardiac arrest, 80% by standard CPR, 70% shock arboretum, a reasonable time to ROSC, and 40% of patients with ST elevation myocardial infarction. In some centers discussed, for example, with American colleagues, they have predominantly non-witness arrest, non-shock arboretums, and non-cardiacosis, so without ST elevation. So you can understand that these patient populations might not entirely reflect the kind of patients you see in other settings. So there might be a problem in the way that you generalize the data of TTM2 to the entire settings all over the world. And so if you translate this in our graph, while it's not effective, there might be, of course, an overlap of patients. Still, the TTM2 trial gave an information, but only for out-of-hospital cardiac arrest. And because of this selection of cardiac causes, shock arboretum, witness arrest, there might be not all the out-of-hospital cardiac arrest patients. There are two other publications which are very relevant, providing controversial results. Hyperion study from France, randomizing no shock arboretum with some specific inclusion criteria related to the use of a suppressor dose and the severity of patients, including in-hospital and out-of-hospital cardiac arrest, showing that hypothermia was effective to improve neurological outcome in these patients. The outcome of the control group was extremely poor, and the fragility index of the study was quite a limitation, maybe. But still very relevant, and most of the effect was observed in the in-hospital cardiac arrest group. And then the trial from Germany, randomizing patients only in-hospital cardiac arrest, predominantly shock arboretum, showing that there was no effect of hypothermia. You try to put this on the same graph, and you see that again there is some overlap between Hyperion and TTM2. But this was effective. This was not effective with, again, a patient population in hospital, which was not entirely the same. So you see that each study is representing a proportion of patients. You cannot entirely put this study together, at least when you look at inclusion-exclusion criteria, and the coverage of the patient might not be the same. So the way you generalize the data and the interpretation of the findings of each of these studies cannot be applied to all the patients. Still, there is maybe some cardiac arrest patients who do not look like any inclusion-exclusion criteria of all these 4 or 5 randomized clinical trials, in which maybe we still deserve some research. This is why I think in the discussion we had when we prepared the guidelines, we said that there is a currently lack of evidence for or against temperature control at lower targets, let's say 33 degrees, in subpopulation of patients. They might exist, but we are unable from the existing literature to clearly identify which patients should potentially be treated with hypothermia and maybe which patients could be harmed by the use of hypothermia. Because don't forget that there are side effects, for example, in TTM2 trial, although this has not been entirely be reproduced in the meta-analysis, there was a higher risk of having severe arrhythmia, so resulting in hemodynamic compromise in the hypothermia group. And of course, there are some missing points that are not covered by randomized clinical trials. What about the quality of TTM? Which means treating a patient with just ice packs, not measuring core temperature, without having a good protocol to avoid shivering, to have a rapid decrease in body temperature, a good maintenance at targets, a slow rewarming, a fever control, when compared to core temperature measurement, an adequate device, as in TTM2, rapid induction of hypothermia, good maintenance, slow rewarming, prevention of fever, and a good protocol to prevent shivering and complication of hypothermia, are these interventions different? We are just at the beginning of understanding the use of high-quality TTM in cardiac arrest patients. We're working on different databases, there are few publications, but the role of this high-quality TTM, of course, so the way that you deliver the intervention to the patients still need to be better defined. For example, the upcoming STEP care study will compare normothermia using device versus not using the device. And finally, I think that we are looking at cardiac arrest as an homogeneous disease, but we can easily understand that these cardiac arrest patients are highly heterogeneous. We have now existing reporting several papers showing that there are phenotypes in patients with sepsis, there are phenotypes in patients in RDS. These phenotypes respond differently to some intervention. Statins, steroids, might have different effect in patients' population according to the profile of the patients. Why not in thinking that there might be different phenotypes of patients in whom TTM at lower levels, 33 degrees, might be effective? And the point is very easy. When the patients arrive at the hospital after cardiac arrest, there will be some patients who are already too sick. These patients have very extreme brain lesions. Whatever you will do, 33 degrees, 37 degrees, different level of blood temperature, the possibility you will change the poor outcome of these patients is very poor. So these patients should not be randomized in a clinical trial. And also, you might have patients who are too well. For example, shockable rhythm with witness arrest, early defibrillation, ROSC after 3 minutes. The patient is sedated by the EMS system and transported to the hospital. If you stop sedatives, you can very easily wake up this patient. And of course, whatever you will do in intervention will not really change the fact that the brain injury is very minimal and no intervention will really provide a further protection in this setting. We have not really found who might be the patients at risk. In the meta-analysis, individual patient meta-analysis, including TTM1 and TTM2, we found that patients with bystander CPR might maybe be harmed by hypothermia, while those without bystander CPR with a more severe injury might benefit from hypothermia. But this, of course, is a subgroup analysis, so it is only hypothesis generating and required to be further analyzed. Maybe neuromonitoring could be helpful. Just 2 papers. This is from our group, multicentric study looking at automated pupillometry. If you have an admission, a pathological automated pupillometry, you have 3% probability of poor outcome. So you can use pupillometry on admission, looking at the pupils, and if pupils are reactive, you can include the patients in randomized clinical trials. But if not, maybe these patients should not be included in this kind of randomized trial. And the second, if you're looking at 2 well patients using a very simple EEG montage in a very early phase, this was a 6 hours, but may also be true very early phase. If your EEG is immediately going towards discontinuous or continuous pattern, the proportion of patients who will survive is extremely high. the brain has been only marginally affected by anoxic injury. And so these patients also are too well. They should not be randomized in a trial, but just to be waken up and stop sedation. So going at the end, I like to cite this statement from a good friend, Paul Young, who's a very high quality researcher, who said, maybe one size does not fit all, and that size is not therapeutic hypothermia after cardiac arrest. Very strong statement against the use of any hypothermia in this setting. Look at high quality randomized clinical trials. To remain more gentle on that setting, I would say that, of course, we are interested in temperature because secondary brain injury might have a role in enhancing the initial injury after the cardiac arrest. We still are now in the area where active temperature management is recommended, because to provide normothermia as in TTM2 trial, you will require sedation. You will require devices in 50% of the patients. Of course, we don't know whether the conclusion of TTM2 are applicable to all patients or only those who look like TTM2 criteria. Clearly, abandoning TTM is not an option. And I think there is an ongoing research in subgroup patients with cardiac arrest that might be in hospital, not checkable rhythm, maybe high quality TTM, maybe looking for responder to better understand how to individualize temperature management in these patients. Thanks a lot for your attention.